We are live, ma'am.
Okay.
Recording in progress.
Join कर लिए. Hmm.
Can just someone confirm if they are able to see my screen?
Join.
Yes,
Yes.
ma'am. Yes, ma'am. We are able to see.
Okay, thank you. So welcome everyone and good evening to this No Thrombosis National Workshop for today. And please give me some time to introduce our expert faculty for today's meeting. So we have Professor Dr. A.K. Thakkar, who is the Director and HOD Department of Neurology, Medanta Hospital, Lucknow. He has held different positions in different institute like Director, Institute of Neurosciences, Medanta, Lucknow, former Professor, Department of Neurology, Dr. RML, Institute of Medical Science, Lucknow, BRD Medical College, Gorakhpur as Professor of Neurology, and University Science, Malaysia as Professor of Neurology, and Al Arab Medical University, Benghazi, Libya as Assistant of Neurology. He has around 140 publications in international and national journals, and he has special interest in infection of CNS, stroke, and epilepsy. And he has around 45 years in undergraduate and postgraduate at various places, teaching experience. So welcome Dr. Thakkar sir for this
Thank
meeting.
you. Thank you very much.
We have moderator for today's session, Dr. Soumya Mittal, Senior Consultant, Department of Neurology, Yatharth Hospital, Greater Noida. He has more than 20 years of clinical experience and worked in many renowned institutes like Apollo Delhi, KMC Hospital, Mangalore, Felix Hospital, and others. He has more than 40 publications in national and international journals, and many articles are published online. And he has also worked on public awareness for neurological disorder through news interview. He has been reviewer and editor of journals like International Journal of Neurosciences, International Journal of Neurosciences and Brain and Nervous System, Current Research, Journal of Infectious Disease and Travel Medicine, BML Open, and many others. He has been member of societies and associations like API, ISA, IAN, WSO, and others. Welcome, Dr. Mittal, sir. We have speaker for today's session who is going to present our case study, Dr. Upadhyay, Senior Consultant, Department of Neurology, Medanta Hospital, Lucknow. He has been member of many academic and society like IAN, MDSI, International Parkinson's Movement Disorder, and IES. His major achievements being reviewer of journal annals of IAN. He has won Best Paper Award in Stroke in INSC 2025, platform paper presentation in AOCN 2022, and he has certificate courses from Migraine Expert Academy, Neurology Update from Cleveland Clinic, Advanced Neurological Disease Management from Harvard School of Medicine, and he's also secured rank 1 in DM Neurology in AIMS Delhi. He has published paper in various journals and his special interest in autoimmune neurology, stroke, and movement disorder. Welcome, Dr. Upadhyay.
Thank you.
And lastly, we also have Dr. Amit Saraf, who is an R&D Gennova, and he has worked a lot in the stroke area and has been pioneered in bringing tenecteplase in India for stroke. So welcome, Dr. Amit Saraf. And now I would like to hand over to you, sir, for further proceedings.
Okay. So should I start or?
Yes, yes, sir.
Okay. So good evening and welcome everyone. We have two very expert, Dr. Soumya Mittal, and a very young, energetic colleague of mine, Dr. Vibhor Upadhyay. And we are going to discuss, I think, two cases. Dr. Soumya is also presenting a case. Is it? Or
No, sir,
he's
he's
moderating it?
yes, moderating.
Okay. So should we start with the case? Or
Yes, sir.
okay. So stroke is a very exciting field now with the all advances which are going on, at least in the acute stroke management. Uh, we have lot of uh, armamentarium for treating acute stroke. Of course, the thrombolysis is one, and which started with 3 hours, then 4.5 hours, and now we are attempting to go extend it to up to 24 hours. Then we had altiplase initially, and now we have 10 hectare and they are all research is going on for newer agents. And then after 2015, there was a paradigm shift by introduction of thrombectomy in selected patients who had LVO. So there's a lot of scope in the acute management, and every case is a challenge. So I think I will hand over to Dr. Soumya to start moderating, and then Dr. Vibhor to present the case, and then we will discuss at the end. Dr. Soumya, please.
I think we'll start with the case first and then come out.
Okay, thank you.
Are my slides visible?
Yes.
Visible.
Yes.
It is visible.
Okay. Thank you, Dr. Sir. Thank you, Mittal sir, for giving me the opportunity to present a interesting stroke case. As stroke means you should be on foot whenever a patient comes in ED. So this is a similar kind of case. So let's directly discuss the case. So she is a Mrs. VD. She is a 79-year-old female. She was a known diabetic, hypertensive, coronary artery disease patient post CABG in 2015. She presented to us with chief complaint of she went to sleep all right at 11 p.m. around, and in the morning after waking up, having slurred speech with imbalance in walking at 6 a.m. There was no history of LOC, seizure, headache, dysphagia, double vision, facial numbness, or incontinence associated with this episode on waking up. And as such, there was also no history of trauma, fall, head injury, or fever preceding to this incident. So when she arrived in the ED, we did a quick examination, and it was suspected to be a stroke, and a NIHS was done, which was around 5 out of 42. Her pulse was 134 per minute, and it was irregular. Her BP was 160 by 86 mm of febrile done at the time of in the ED was 154 milligram per deciliter, and saturation and other vital parameters were normal. She was conscious, and her last known well time was 11 p.m. when she went to sleep and came to ER at 7 a.m., which was 8 hours around from the known well time. So clearly it was a case of wake up stroke. So on clinical examination, she was having dysarthria. People were bilaterally reactive to MM. Nystagmus, horizontal nystagmus was present, and there was left UM and facial palsy. And there was left hemiparesis. Power was around 4 plus by 5, and she was having imbalance in walking. The gait was ataxic, and left plantar was extensor. So urgently, a stroke code is announced in the emergency, and patient was directly shifted to NCCT head for the NCCT head in the CT console room. And when we did the CT, this was our CT scan. Which was showing up old chronic hypodensity in the right frontal region. And apart from that, there was no such early ischemic changes. So we, as a protocol, after doing a CT scan, we did a CT angiogram for the patient, as it was she was suspected to be a stroke patient. And when we did a CT angio, so we can clearly see that there is left vertebral is seen, but the right vertebral is not visualized, and above that the basilar artery is not getting formed. So it was a case of basilar artery occlusion. Here we can see it clearly. So urgently, as it was a clear-cut case of posterior circulation stroke, and the time of onset, it was a wake-up stroke. We wanted to see that was it really a 8-hour stroke, or as the early CT cannot identify clearly the hypodensities in the posterior circulation, we immediately shifted the patient to MRI console room to see the diffusion flare mismatch. And this was MRI done, and it can clearly show that there is a left pontine infarct, diffusion restriction, and there was a ADC reversal too. And so just and the flare images I am not able to add, but there was no flare changes in the pontine region. So after obtaining the consent for thrombolysis, patient was thrombolized with injection tenecteplase at 0.25 mg per kg, and dose given was 15 mg bolus dose, and O to needle time was 40 minutes. And after bolus tenecteplase, we also explained the patient priorly only after seeing the basilar artery occlusion that the patient will need mechanical thrombectomy, and our IR team was ready and explained all the pros and cons of doing that procedure, and the family was ready for it. So after thrombolizing the patient, we immediately shifted the patient to cath lab for thrombectomy, and the successful basilar artery thrombectomy was done for the patient. Then after that thrombectomy, patient was shifted to stroke ICU, and a repeat CT scan was done at 24 hours, which showed no evidence of intracranial bleed. Post thrombolysis and thrombectomy, her vitals remains normal. Pulse was 92, but still there was atrial fibrillation. There was no headache or worsening of neurological deficit. Her NIHS improved from 5 to 2, and sugar remains well controlled. Her echo was done to see any clot, LA clot was there or not. So there were no valvular heart disease, no evidence of LA clot, and LA size was also normal. But definitely patient had to begin with, at the time she was having irregular pulse, and ECG also showed that she was having atrial fibrillation. So this was her CT scan, which we did after 24 hours of thrombolysis and thrombectomy, which showed some subtle hyperdensity in the Poncine region, but as such, as there was a basilar artery occlusion, so it may lead to catastrophic posterior circulation stroke, which was prevented in this case. So later on, at the time of discharge, patient was started on apixaban because she was having atrial fibrillation, and NIHS at discharge was 2. So the final diagnosis for the patient was it was acute ischemic posterior circulation stroke, basilar artery thrombosis, post thrombolysis and thrombectomy. TOAST, according to TOAST classification, it was a cardioembolic stroke, non-valvular AF. NIHS at admission was 5, and at discharge it was 2. So the salient points I want to discuss in this case, that all wake-up stroke to be considered for intervention, and time of onset can be within window period even it is a wake-up stroke, because we never know when did the stroke happen. And like in this case, there was a diffusion flare mismatch clearly, and it was a large artery occlusion in posterior circulation, which also helped in doing thrombectomy. And one more thing I want to point out in this case, that NIHS in posterior circulation stroke may be falsely low because it predominantly counts for the anterior circulation stroke, and the points which are there in posterior circulation stroke are falsely not counted in the NIHS, which may lead to falsely low NIHS scoring. And posterior circulation stroke, especially in basilar artery thrombosis, nowadays now recent studies have come up in last 1 to 2 years, are showing promising research for thrombectomy up to 24 hours of onset of stroke. So this is one article which shows the pitfall of NIHS, where time we need to think of new clinical entity for especially the scoring system for NIHS in acute stroke for the especially the posterior circulation, where they have clearly pointed out in this article that it is disproportionately biased towards deficit caused by lesion in the anterior circulation, such as motor function and cortical sign. In contrast, the posterior circulation deficits like cranial nerve abnormalities, ataxia receive fewer points or may even be excluded from the scoring. So they have done the comparison study and also found that NIHS for anterior circulation was higher as compared to the posterior circulation. And some of after knowing this, some of have also made some known as post NIHS scoring, but still it's not widely used, and we are using the this normal NIHS scoring. So this needs to be considered in future research, that we need some modification in the NIHS score. And these are trials which have recent come up for endoscopic treatment of acute basilar artery occlusion, like this one last year done in the Chinese population, where they divided the acute basilar artery obstruction cases in two arms, where thrombectomy was done, and another group, the best medical treatment was given. And we can clearly see that a MRS score of 0 to 2 at 90 days was achieved much more in the thrombectomy group, 33 at percent, as compared to the control group, and the overall mortality at 90 days was much less in the thrombectomy group as compared to the control group, where they received the best medical management. So to conclude, that even till 12 hours, this study has clearly shown that moderate to severe ischemic stroke caused by basilar artery occlusion till 12 hours had which have gone endovascular thrombectomy as compared to best medical management has shown the good functional outcome with little more risk of hemorrhagic conversion. But definitely the MRS score and the mortality at 90 doses much better as we compare it to the symptomatic ICH. Similarly, this recent published study where they have done up to 24 hours has also shown that going up to 24 hours with the intervention of thrombectomy in basilar artery occlusion, the thrombectomy group has shown a good functional outcome at 90 days as compared to the best medical management. And though the symptomatic ICH will remain higher because as the time progresses, the intervention definitely increases the chance of symptomatic ICH, and the mortality at 90 days is also less in the group of thrombectomy patients as compared to the best medical management. So with this, I end my this case. Thank you, everyone. And we should remember that time is brain and always be on toes whenever a stroke patient comes.
Okay, thank you. Thank you, Dr. Gore. Dr. Soumya, please make a comment.
I think that was a very crisp presentation, no doubt about that. And the points that you have raised are very nicely put. That first, the PCA territory, thrombolysis and thrombectomy, which were not really suggested previously, they are coming in.
Yes, sir.
To give us benefit. So that is a very nice thing. And the NHS is biased towards the ACA territory. That's always a known fact. So that is always an issue that should have come up. And how frequently would you prefer to do a MRI over a CT scan?
Sir, only in cases of wake-up stroke or the last known well time is unknown and proper history is not available for the onset of the stroke. In those cases, or otherwise, if CT is showing the signs of aspect score is good, or somewhat we can correlate that it is 100% stroke and aspect score is coming more than 7, then we don't tend to do MRI. We do CT perfusion although in those cases where we need to take the decision.
In this case, why was CT perfusion not preferred?
Sir, due to the time constraint, we immediately shifted the patient for MRI to save the time for thrombolysis. Otherwise, we are going to take up this case for directly for thrombectomy. So just we, with the hope of that we can thrombolize the patient, we thought of getting MRI first time.
The diffusion flare mismatch that has really helped to extend the time window.
Yes, sir.
Thrombolysis as well as thrombectomy, no doubt.
Sir, can I ask one question? So I was just curious, from the time of thrombolysis till the start, so how much time did you take from the thrombolysis to the initiation of EVT?
So just outside the MRI room, we gave the bolus dose of tenectase, and after that we shifted the patient. So it took around 20 to 30 minutes to prepare the cath lab and arrange everything ready for the patient.
Because some of the studies have shown if there is, I wouldn't say delay, but if there is some time in between the thrombolysis and EVT, some of the clinicians have told me, they have seen in their own anecdotal experience and data also shows that clot seems to lyse better in the tenecteplase group, and some patients didn't require EVT. So in your experience, have you experienced, essentially bridging, but where the patient did not require EVT?
Not per se, but in one patient, I remember that it was an anterior circulation stroke. And after we did IVT and patient was shifted to EVT, so the clot do get smaller, but it went distally more.
Okay.
So it become from LV, become a MIGO.
We had a case who came with an MC infarct and there was a clot in M1. So at that point of time, we had thrombolysis and then we shifted the patient for a thrombectomy. And in the check DSA, when we did the DSA, there was no clot. It had already opened up. So it had completed, but the patient was just returned from the lab.
So IVT worked perfectly.
Any other question from the audience? I think it was a very crisp presentation.
So far.
And I think that we are shifting from a time clock to biological clock. So if there is a perfusion diffusion mismatch is there, then we should not waste. I think that is the lesson from this case. Though the NHS was only 5, the intervention was done aggressively and the result was there. And in posterior circulation, one cannot take a risk, particularly if there is a basilar artery thrombosis. So I think this was a very right decision, and the case should be dealt in the same way. And since the patient had atrial fibrillation, there was always a chance that patient may through another embolism. So the intervention was very much justified. And that's the result is showing. Have you done any follow-up of this patient? Has she come to you again after that, Dr.
Yeah,
Vibhu?
yeah, sir. She is being followed up in the OPD.
Yeah.
So 2-3 months back she came. She's on Apixaban and she is doing fine. Now
Okay.
her MRS is almost 0 to 1. Like,
Mm.
it is a little imbalance in walking. Rest she has recovered.
I think all posterior circulation we do. Uh, what is your because posterior circulation cases are slightly different from the anterior circulation. So what the protocol? You have a different protocol for them, or because in this case, if you see clinically, you can't make out it's a posterior circulation program.
Yes,
It's a
sir.
left-sided
Hmm.
hemiparesis.
Yes,
So
sir.
only you are lucky that you got an infarct and MRI.
So
But suppose if MRI is not available in
hmm.
such cases, what will be your line of treatment?
Then, so sir, definitely we have, if perfusion study is available, we can try. But perfusion studies, though, also is not very much give conclusive results for posterior circulation. For
Yes.
anterior circulation, they do help, but for posterior, again, perfusion has little restrictions. So in that case, I would have just directly shifted the patient for thrombectomy only. IVT would be a little riskier.
So, no, I think that I mean, we have to follow the same protocol. We do CT and CT angio together.
Yes, sir.
And if there is any evidence of LVU, we should proceed.
Yes,
Isn't
sir.
it? We should not wait
Hmm.
for the MRI confirmation or anything.
Hmm.
I think that's Dr. Abhijit's question was in this way only.
Hmm.
So he wanted to know whether was a really MRI justified or no. We had a satisfaction. Yes, we have proven that there is an infarct. But if there is an angio is showing basilar artery occlusion,
Hmm.
then we can straight away go ahead with intervention. But Dr. Soumya, what is your say on this point?
Sir, definitely. I mean, if we have a basal artery occlusion, we should take care of it. But then, in this case, being a wake-up stroke, we needed to know whether it was really whether we had to.
Yes, sir.
No,
Exactly.
no, no, but already we know that there is an occlusion at basilar artery, no? So should we really take this patient for MRI, or straight away without MRI we could have done the thrombectomy?
I
That
think
is
the basilar artery was already occluded. There was no visualization.
yeah.
Hmm.
So we really needed to see whether it was really up to it, because if it was a completed stroke and we had a completely occluded basilar artery, then it might have been pointless.
Hmm.
Might have actually put the patient at risk of bleeding in the PCA territory, and especially in the brainstem. A bleed could have been disastrous.
No, but given the background of atrial fibrillation, the chances of embolism is very high.
They are higher.
So in that case, I personally feel we should have gone straight away for thrombectomy, even if MRI could not have been done. It has been done, it's good. But then that time, 20 minutes could have been saved. But luckily, the patient's NHS was low. So I think that adds to this, whether we confirm it or not. So any other question or comment?
Just sir, usually we did MRI because the one more factor, because to counsel the family that it is really a stroke, and the cost associated with thrombectomy is usually in lakhs, at least 3 to 4 lakhs. So family also get little counseled. In
Yes,
a
I think that's a very valid point.
Mhm. That one
Yes,
thing is little helpful in convincing the family for it.
yes. So if everyone agrees, then we can wrap up this discussion today. Dr. Soumya?
Yes, sir, absolutely.
Okay, thank you. Thank you, Dr. Vibhu. Thank you, Dr. Soumya. It was nice. The case was very nice. The result was nice. The follow-up is nice. And so I think all credit goes to Dr. Vibhu and his team. Thank you. Okay, thank you. Over to Dr. Pratiksha.
Thank you very much, sir, Dr. Thakkar, sir. And thank you, Dr. Soumya, for the interesting moderation. And especially thanks to Dr. Vibhor to bring such interesting cases. And I guess we will continue with such meetings, throughout, and bring such interesting cases and have a good discussion. So thanks to everyone, and I guess we can wrap it for the today. So good night, everyone, and let's meet next time. Till we meet next time. Thank you.
Thank you, Rakesh. Thank you, Mr. Sir. It was nice collaborating.